Yes, sir. Any question? So once you give the green signal from your side, I'll start.
Yes, sir, we can start.
Wonderful. Excellent. I need such a
Yes, sir, we can
active
start.
participant. Wonderful. So get ready and concentrated now on the questions. These questions are, believe me, I literally worked very hard to just prepare whole the things, right? Whole the day, right? And trying to compile this all excellent slide for you. So I wish and I want you properly concentrate on each and every MCQs, right? So let me start with the first questions. Get your all pen and papers ready. So that would be great. One sec. Sorry.
Hello.
1 minute.
Hi, yes.
Everyone can see my screen?
Yes, sir.
Yes.
Great. Great. So let's start without wasting the time. So we'll first jump on the first questions of the day today, right? This is the questions in front of your screen. This is what the highlighted. What today we are going to discuss in the class is everything we're going to discuss today's class is these topics, right? So just keep this topic in your mind. This is what we are going to discuss, right? So we are going to discuss colonoscopy here. We are going to discuss malignant melanoma, cervical cancer, lung cancer, breast cancer, tumor marker, testicular tumor, skin disorder, skin cancers, right? High and high grade this lesion, oscus, breast cancer, smoking cessation, related questions, and cervical intraepithelial neoplasia, right? So this is what we are going to discuss today, right? So let's go for the first questions in front of your screen, right? So first question is this: a 50-year male, right? Uh, no hypertension, no diabetes, chronic smoker, presented with the positive occult blood stool and family history of colon cancer. The best screening test for colon cancer is MRI abdomen and pelvis with contrast, CT scan abdomen and pelvis with contrast, colonoscopy, ultrasound, and stool for occult blood, right? Stool for occult blood and capsule endoscopy. So just try to think over these questions at least for 10 seconds, 15 seconds. You won't get in the exam more than 15 seconds, believe me. So you need to concentrate properly what exactly they are trying to ask you, and you can post the answer. Fair enough. So most of the people are saying the colonoscopy, and that's the answer. Now let's open this session for discussion more, right? First of all, any volunteer quickly, right? We'll discuss these questions one by one, nothing hurry. right? First is the colonoscopy age and frequency. So there are two, what I mentioned here, few other exam related questions. So what are that along with the colonoscopy? So colonoscopy age means what age you start the colonoscopy and when you stop the colonoscopy. This is first question in exam. What is the frequency of colonoscopy? That is second question in exam. Why not sigmoidoscopy? Why colonoscopy? That is third question in exam. Most sensitive and specific test for colon cancer screening is another question in exam. And special condition, when you have first degree relative with the colon cancer, how you approach, second degree relative, how you approach. There are more than 3 generation in the family or 3 generation having a colon cancer, and now somebody asking you for the colon cancer screening, how you approach. So this is the guideline. So these are a lot of 5 6 common questions, right, related with the colonoscopy. So this is one of the example, right? So answer for this question is absolutely a colonoscopy, not no doubt about it, right? Why? See the 50 years male, no hypertension, no diabetes, means there is no chronic smoker, presented with positive stool occult blood, right? So what is positive stool occult blood? Stool for occult blood, right? That means you did a stool test, and in stool test the occult blood is positive. So this occult blood is positive could be because of two reasons: either benign condition or it could be a malignant condition, right? Benign condition are what condition? Ulcerative colitis, Crohn's disease, right? And then chronic GI condition, right? Peptic disease or some other colon disorder, right? Where you get the same stool for occult blood, right? You can get the stool for occult blood. So it's not just the malignancy, but what we don't want to miss being a doctor is the malignancy, right? So malignancy you want to miss, don't want to miss. That is why you are going for colonoscopy. Let me discuss why you did not selected the, say for example here the another option here if I can put is a sigmoidoscopy. Can anyone tell me why not sigmoidoscopy? Right, sigmoidoscopy, that is also an answer. So you have two on, I mean you have query either sigmoidoscopy or colonoscopy. So you selected colonoscopy. I'm happy with the answer, this is the correct answer. But why not? You need to know why not. Anybody, very quickly, anybody, why not
Because sir,
sigmoidoscopy?
40% of the tumor markers can be missed out because of the proximal view.
Excellent, excellent. But little change in the wording, sir. You hit the perfect things, not tumor marker. The 40% of the cancer can be missed. So let me draw you and tell you what is exactly why not the colonos these things and why it is this. So let me get one blank page if possible. I don't get any. 1 second. Huh? It's little here, just for more clarity. So what is the colonoscopy and what is the sigmoidoscopy? So basically, what this is the this is cecum, this is appendix, right? From cecum here, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. This is what the general structure is, right? This is on the right side, obviously, appendix and cecum. This is left side of the colon. This is large intestine. So what happens when you pass the scope from colon, right? Here, the sigmoid colon, right? Ascending colon, transverse colon, descending colon, right? Descending colon, sigmoid, rectum, anal canal. So this is how the general structure is anatomically, right? So what happens when you go through the sigmoidoscopy? You can see up to the sigmoid. You can see up to the sigmoid. But what beyond the sigmoid? So the gentleman told 40% of the tumors are situated proximally, proximally to the colon. I mean, sorry, sigmoid colon. So here you can see up to this part in the sigmoid colon. But what if the tumor is situated in transverse colon? What if it is situated in the hepatic flexure? What it is situated on the splenic flexure? What if it is situated at this junction? So all the cancers you can miss by not doing the colonoscopy. So the word is full length colonoscopy. So what is full length colonoscopy? It enters from the anus, rectum, sigmoid colon, descending colon, transverse colon, anal, and sorry, ascending colon up to here. So full length of colon you can see with a full length colonoscopy, and that is why it is a investigation of choice, right? So sigmoid colon can miss up to the 40% of the tumor, which is located statistically proximal to the sigmoid colon, and that is why the colonoscopy is the answer for your understanding, right? Is that clear, sir? Is that clear? Yes
Yes,
or
sir.
no?
Totally. Totally, sir.
Wonderful. Wonderful. So this is what the explanation is, right? Another things, right? Let's also cultivate the practice of excluding one by one. Just not, we don't need to just give the answer or mug up the answer. If you ultimately understand the logic of answer, you can answer any questions, believe me, right? So MRI abdomen and pelvis with contrast, why not? So let me tell you why not. Even if you do MRI pelvis, you find that okay, there is a uh, I mean, splenic fracture, there is a tumor, or it's a descending colon, there is a tumor. So even after doing the MRI, you need to do the colonoscopy. Even after doing the CT scan, you need to do the colonoscopy. Why? Because biopsy is the ultimate answer, and you cannot do the biopsy with any radiology. So one thing basic gets fixed in your mind. Whenever you want to diagnose any malignancy, any cancerous in your body, biopsy is a mandatory. Radiology will give you the idea, or it gives you the suspicious about malignancy. It cannot confirm the malignancy, right? Even though there is a huge mass, radiologically CT, MRI you do, but it is not a confirmatory test. And what they are asking, based screening test. So even after doing the screening of MRI and CT, you again need to do the confirmation colonoscopy. So why don't you go directly upfrontly with the colonoscopy? Ultrasound, it's not good test. Stool for occult blood, yes, but it is again not more sensitive then colonoscopy, right? Again, the stool for occult blood, if it is positive, again, what's the problem? You need to confirm whether it is benign or malignant. How do you know? Again, you have to confirm. Both the things can be confirmed by colonoscopy and capsule endoscopy, right? Where the only limitation is capsule endoscopy can see whole the GI tract. It cannot do the biopsy. So again, even after suspicion in the capsule endoscopy, you need to do the biopsy. So ultimate answer is the colonoscopy, which is highly sensitive and specific test for colon cancer screening, right? And suspected case of malignancy in the GI tract, especially the lower GI. Upper GI, you go for upper GI endoscopy. For lower, you go for the colonoscopy. Any quick questions for these things? For this MCQ, any quick questions? I try my level best to solve few questions in a one question. Any question in the house? I'll spend 15 seconds for any questions. Open for
Why
all.
is sigmoidoscopy done, sir?
Sigmoidoscopy is done especially when there is a, I mean, clear-cut radiologically evidence of tumor in the sigmoid colon or below the sigmoid colon, where you don't need to enter whole the scope, right? Because when you did either sonography or CT scan or MRI, you find that there is a specific, there is a tumor at sigmoid colon or rectosigmoid junction, then colon sigmoidoscopy is good enough. Again, by doing the sigmoidoscopy, you are going to get the biopsy. Got it?
Yes,
Right?
sir. Yes,
So,
sir.
but they ask you in the exam colon cancer, and colon is not up to the sigmoid colon. Colon is up to the ileocecal junction. From there, the real colon starts, right? So, if you want to
Yes, sir.
see the whole colon, go for the colonoscopy. Is that clear?
Yes, sir.
Sir,
Thank you.
colonoscopy is gold standard for screening as well as for definitive diagnosis.
Yes, exactly, exactly. But even in healthy, so now that's our second question. So let me jump to the second question in the same question. So let's discuss very quickly this exam oriented questions, right? Colonoscopy age. So what is a colonoscopy age? So you must remember it starts at the 50 and stop at 75. Mugab, this age mugab. This is one question in exam. Frequency. So what frequency? Every 10 years. So if your father or mother has no complaint, absolutely asymptomatic, living healthy life, but they ask, yeah, if they ask that you need to do the colonoscopy, what's the frequency? So tell your father or mother, start at 50, do it at 60, do it at 70, right? Up to 75, that is the international guideline for doing the colonoscopy. After 75, there is no survival advantage, and that is why people are not doing it, right? So you screen and you can enter anytime, not 50, 55, 60, but earliest age for the screening is 50. So this is exam question. So two is solved, age and frequency, right? Why not sigmoidoscopy? I told you 40% you can miss. That is why you need to do most sensitive and specific test. Again, colonoscopy, I tell told you already, a special condition for the colonoscopy guideline. That is the last very important and interesting questions, right? So that I will discuss right away. So related with the colonoscopy, all the queries has been solved so far. This chart is a tremendous, very interesting. I love a lot this chart. You should mug up this chart, right? We are always confused ourselves for this chart. So there are 5 things. One is a general population, means like you and me and my father, mother, and all these things, right? Family member with colon cancer, second entity in the exam. So these are the 5-6 questions. This chart has 5-6 question in one chart. Third, fourth, and fifth, right? So now special condition. This is general population, right? So general population, I told you, start at 50, stop at 75, do it every 10 years. That's it. This is question, right? So screening age is start 50 every 10 years. So this is 2 question is covered in this. Little switch the gear, right? Little complexity. What if there is a single family member with colon cancer? Then what's the screening protocol and what's the frequency? So little change from 50 here, remember age 50, here the age is 40, or 10 years before, the gentleman in the family who got, say for example, the gentleman got the cancer at 40 years, say for example, right? Single family member who got 40 years of age cancer, and now the family, another family member asked, when I supposed to start? So earliest is 40, but or 10 years before, at the what a gentleman acquired, B has to start at the age of 30 years, 10 years before, when the first this family members got the cancer. So here little change, right? When there is a single family member with colon cancer, so you start at 40 and frequency is the same. So here 40 by 10, here 50 by 10. General population, start 50 years, do every 10 years. Here start 40 years, right, and repeat at 10 years. Little change in the more complex scenario. This is single family, 3 family members, 2 generation, and somebody is less than 50 years. What to do? See now, here colonoscopy has 1 to 2 years. See the change. Instead of 10 years, now every 1 to 2 years, and instead of 50 years, here we started almost half the age, 25 years. When there is a 3 family member, 2 generations, somebody is less than 50 years, you must keep this thing in mind, and they will ask you these questions in your exam. Fourth scenario, FAP, familial adenomatous polyposis, Gardner syndrome, Peutz-Jeghers and Turcotte. Four syndrome, mug up. Familial adenomatous polyposis, Gardner syndrome, Peutz-Jeghers and Turcotte. So this 4 syndrome, anything they can ask. They can ask you the question, 40 years of male presented with blah blah blah, diagnosed as a Turcotte syndrome. What could be the frequency of colonoscopy? See the beauty here. The colonoscopy start at 12 years, gentlemen. See here, normal population 50 years. Here 12 years. 12 years is quite young boy, right? And not 10 years. Now 1 to 2
Sir,
years.
here we will do sigmoidoscopy, right?
Yeah. Yeah, at least do the sigmoidoscopy. You can convert into the, because this 4 condition, almost there is a lesion everywhere in the colon. If you get such a patient, almost you get the, I mean, disease and lesion in whole the colon, right? So this is the range. And juvenile polyposis, no extra recommendation. It is as good as general population. That general population means first start at 50 years and do it at 10 years. That's it. So this is what the thing is. There is nothing, no magic, no miracle, right? You need to just remember, simple. This chart is very simple. I took it from Master the Board USMLE step 2, 3, right? But we just every time see it, but we don't concentrate the way I concentrated, right? So you now just keep this slide in mind, right? I'll share this PowerPoint with you. So don't worry. Each and every slide will be in your mailbox in next 3 hours, right? But just try to understand the logic. Is there any confusion? Is there any confusion? Anybody?
No, sir.
Excellent. So this is, I
No,
think we pack up with the whole colonoscopy related questions, right? So if you remember it well, I think nobody will stop you from answering you the correct answer of colon or colon related things. Let's jump and move to the next interesting question. A 36 years old man has been diagnosed with a superficial spreading malignant melanoma. So again, those who are new in this meeting, let me tell you, without 3 things, you never going to be an expert of any MCQ. First, you need to know the diagnosis. Whenever you have any scenario, any questions, any vignity clinical, you must know the diagnosis, whether they ask or not. Second thing is how you investigate this patient and what is the treatment of this patient. So if you cultivate the mastery, or if you cultivate this asking three questions to yourself, irrespective of, they ask you the three things, right? 95% plus questions MCQ in any exam, whether USMLE or DHA, HAD, MOH, OMAN, SMLE, KMLE, you name the things. 95% questions either diagnosis, either investigation, either treatment. So in one question, at least you make a 3 MCQ yourself, right? The way I'm doing it. In one MCQ, I made 10, 15 MCQs in colonoscopy, right? So let's concentrate. Keep this formula in mind. You will be very happy in exam. So 36 years of mild diagnose. So diagnosis is done. They already given you the malignant melanomas. Out of 3 job, 1 job is done. What is the diagnosis? Right, malignant melanoma. Which of the following factor determine the prognosis? Right. So size of the lesion defines the prognosis. Shape, thickness, color, or patient's age. Very interesting. Simple but interesting. So you think over it for 10 seconds and post answers in chat box. What do you think? What could be the answer? Is it if the increasing the size will going to kill the patient fast, or what? Right. So somebody's also posted the color of the lesion. So honestly speaking, color of the lesion is not the prognostic factor, honestly speaking. Ashish Bhatt has posted shape of the lesion. So shape is not also the things. Somebody Samsung SM posted a size of the lesion. So that is also not a things. So the correct answer is a thickness of the lesion. Let me go to the literature of this. So you will better understand this clinical scenario, right? So this is the things. So what's the correct answer, right? So first of all, how you diagnose, as I told you, how you diagnosis is the best done by the biopsy. Biopsy diagnosis is best performed with a full thickness sample. So this is the skin, and if you find this is the lesion, so you completely remove whole, completely with the good margin, right? So biopsy diagnosis with base performed with full thickness sample. This is what full thickness sample, right? Because tumor thickness is by far the most important prognostic factor. Again, everybody knows prognosis, prognosis, prognosis. Let me clarify what is the prognosis. So prognosis is means when somebody diagnosed with any disease, either it is a benign or malignant, either it is hypertension, diabetes, or cancer. Once they diagnose, how long they live, how long they live, a good quality of life, that is called prognosis, right? So good prognosis, bad prognosis. Good prognosis means they live good life, longer life with any complaint. It's a good prognosis. Bad prognosis, they die fast. Bad prognosis. Blood cancer, if untreated, say for example, acute myeloid leukemia means blood cancer. Untreated prognosis is very poor. Why? If you don't treat acute myeloid leukemia within 3 months, 98% of the patient will die. That's it. So prognosis is bad. You need to do something urgent for this patient to make them survive, right? So here the thickness is the main important. The thickness of the lesion, right? And there is another question in exam. Which score? Breslow was the name of the person who did this classification. So Breslow's classification we'll see. So thickness of the lesion. This is the one very nice A, B, C, D, E. A for asymmetry, right? A is what? When this is a lesion, right? So this is a symmetrical lesion, means very regular. This is asymmetrical lesion. So this is again a signs of suspected case of malignant melanoma. How do you know that this patient has suspected melanoma? When some patient comes to you in your clinic, right? And in your clinic, if the patient comes to you and you see the skin lesion is asymmetrical, that is A, right? Borders are irregular, right? When there is a non-cancerous or benign, it's a regular, right? Border is irregular, right? This is irregular. Change in color. Color is absolutely same in whole the mole. Here change color, here change is color, here change. So within a one lesion, there is a change in the color. This is a malignant sign. Diameter. So diameter here is a fixed, here irregular diameter. You can't, I mean, there is not symmetrical spreading all around. It's all irregular because of cancer, right? And evolution. E for evolution, mole that has gone through the sudden changes in size, shape, and color. So 2 months before it was this much, after 3 months it's like this much. right? So change in asymmetry, border, color, right, diameter, and everything is all gone. So this is a suspected sign of malignant melanoma. So any patient comes to your OPD with a skin lesion, look for the malignant melanoma. It is not a very rare cancer, right? But you should not miss it, right? So there are three cancers which is that we're going to cover it obviously in the same session, right? So basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, right? So we will discuss in questions as well. So this is what the interesting part is, right? So let's just jump to the score. This is the Barlow's, right? So 5-year survival. Can you see this thickness increase, right? Thickness increase, the life decrease, right? In situ, very early stage 0, prognosis is good. 5 years survival, almost 100% people will live up to 5 years. Less than 1 millimeter, again 500%. Now see, the thickness is increasing, the lifespan is decreasing. And if you can see more than 4 millimeter, so this is a skin, and if the involvement of the melanoma is 4 millimeter or more, right, the survival is 50%. So what does it mean? That at the end of the 5 year, 50% patient will live and 50% patient will die. So more than 4, the prognosis is not good. See here, so this is the melanoma lesion. So here you need to do completely excisional biopsy, right? You need to do complete excisional biopsy to get the idea, right? So thickness is the prognostic factor. That is what our question is, right? If you can concentrate on our questions, what was the, right, what was the prognostic factor? So prognostic factor is what? The thickness. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. Next question, cervical cancer. Just get ready with the cervical questions. Probably you are very much expert in cervical cancer. A lot of questions coming in every exam. Must 100% coming. Cervical cancer vaccine active against all except. So you need to rule out something which is not active, right? Nobody will give you the clue in the exam. I am giving you. So cervical cancer cancer vaccine active against all except. So that means there is something in the list which is not much active. So HPV, that is human papilloma virus, 611, 16, 18, 23, 24, none of the above. So you need to figure it out. You can post your answer in the chat box. That's fine. Okay, great. So almost the whole full house is correct. Answer is C. Yes, that's extremely perfect answer. So now let's first discuss the few other questions, because I try to make a lot of question in one questions, few other questions, right? Any one volunteer, right? If Dr. Amal, if you can speak up one by one, I'll name the things. If you are interested, don't take it otherwise. Not targeting the people, but you will learn more. So screening age, frequency with HPV. Yes, Amal. Dr. Asit Bhatt, any comment, sir? Any comment? Screening age. Screening age means cervical cancer. Screening age. Yes, tell me.
Yeah, it's starts about older than 21 years of age.
Okay, great.
I think pap
Yes,
smear, pap smear every 5 years up till 35 years. Then above 35 years, sorry, sir.
No problem. No problem. This
Yeah.
is learning platform. At least I'm happy. At least
So
you are
after
interacting
65
with
years,
me.
screening stops, but the middle part, I'm a little bit hazy.
No problem. So let me first answer the first question clear cut. Very frequently asked question in exam and on all platform. So what is the screening age for cervical cancer? So start at 21 years of age. Stop at 65 years of age, because there is no survival advantage. That is why 65 you stop. If you are doing with the right pap smear, modality, right? Pap smear, do it every 3 yearly, every 3 yearly. So this is the thing. So when you are doing with the pap smear, 21 you stop at 65, do it every 3 years, and the name of the test is pap test. Little change in the scenario. If you are doing with the HPV, human papilloma, HPV DNA test, if you are adding to this, right? So you do the pap test, you do the HPV, then the everything is same, 21 to 65, but instead of 3 years, now you do it at 5 years. If it is negative, provided this pap smear is negative, this is also negative, pap and HPV. So if you can't detect the human papilloma virus, right, and your pap smear is normal, you do it 5 years. Is that clear? Yes or no? Very transparent, very clear cut. Any confusion? Great.
No confusion.
Wonderful. Treatment of CIN3. CIN is what? Cervical intraepithelial neoplasia. So first of all, you need to understand what is cervical intraepithelial neoplasia. So that we discuss in one of the questions. So I'm keeping this I part or treatment of CIN a little away. Pap smear technique, you go and read, right? How the pap smear can be taken, right? It is not a rocket science, right? You can learn, any general practitioner can learn, right? Especially the female, they can learn how to do the pap smear is a simple test. How to read, once you did the pap smear, how to read the pap smear, that comes in the I mean MCQ later on, so I'm not discussing and going along. Cervical cancer vaccine you must know, and commonest histology. Anybody knows what is the commonest histology in cervix? Right, this is a uterus, right? This is a cervix, and this is vaginal part. Here the two fallopian tube, here ovaries. This is just general. My figure I know not much good, but it's just for understanding, right? So in cervix there is a endocervix and an ectocervix. So ectocervix usually they have squamous cells. So commonest histology is a squamous cell carcinoma. Exam question. Commonest histology in cervix. Second commonest adenocarcinoma. What is adeno? When ecto and endo fusion, it is called fusion area. Go and read little anatomy of cervix, right? Where the endocervix and ectocervix join, it's a fusion area. There area you get the and adenocarcinoma, right? Because of there are a lot of gland, right? So you can see adenocarcinoma. So these are the questions. So here what the answer basically, right? 6, 11, 16, 18. So this fourth strain, this is a viral strain, HPV, human papilloma virus type 6, 11, 16, and 18. Almost 70 to 80% of the cervical cancer is because of this strain, because of this four strain, right? So it is covered very well. And what they are asking, cervical cancer vaccine active against all except, so they are not active against this, right? So still, right, there is a chances, if it is a 23, 24, there is chances even after getting this quadrivalent 1, 2, 3, 4. So there is vaccine available in the market, quadrivalent. Quadru means 4, right? So 4 strain containing, right? Which 4? 6, 11, 16, 18. There is a one vaccine which contains all 4, which is given to the male and female. Let me tell you very clear cut, because HPV does not only cause the cervical cancer, it is the virus which is responsible for anorectal cancer as well in male and female. So it not protects against the cervical cancer, it also protects against the anorectal cancer caused by the HPV, right? So this fourth strain is covered very well. So here answer they ask except means not covering well is this, right? So answer is C, as everybody knows, right? And this is the name of the vaccine called as a Gardasil, right? So I must recommend on this platform to you, the female doctors, your mothers, your sister, your family, your friend, anybody, right, who is not vaccinated, just get vaccinated tomorrow. Vaccinated, because this is the one vaccine which prevents cancer. Believe me. So it is a wonder. It is a wonder. So if you not, don't take it lightly. Oh, I'm fine, I have no problem, I'm very healthy individual. Go and get the vaccine. That's it. Simple. Like you are getting BCG, you are getting polio, you are giving your kids BCG, polio, DPT, hepatitis. Everybody has done across the globe COVID virus vaccine. even booster third dose we took, right? Nothing happens. It's good for us, right? It saved many lives, right? So go and get it. But nobody knows about the vaccine. So you need to educate yourself first, and you need to spread the awareness in the society about this cancer vaccine, because many people doesn't know such kind of vaccine is available in the market. So it's your job, it's my job to tell them. Switch to the next question. We'll discuss the remaining other few questions in the later question. There is a CIN we'll discuss. Commonest histology of the lung cancer is small cell carcinoma, non-small carcinoma, poorly differentiated carcinoma, and neuroendocrine tumor. Quick. It's a very simple one-liner questions. Make it little fast. Yes, Sonali, what's your idea? Sonali, if you are interacting with me, I would be happy. Can you little bit speak up, Dr. Sonali? Yes, Dr. Sahar, Dr. Saima, anyone, volunteers, anyone.
Histologically, usually the commonest is a small cell carcinoma.
Small cell, by your experience, it's small cell, isn't it? Yes or no?
Yes, yes.
Okay, great. Let me check. Tell you the real literature. Anyway, I'm just trying to. Yes, Dr. Saima, Dr. Sahar, any comment?
Sir, it is small cell
Yes, sir.
most common.
Sorry.
Fair enough.
Sir, I also read small cell lung cancer is the highest among the histopathology, but maybe I am wrong. But just a few days back, I just read it that small cell carcinoma is the. So it's
No
I'm
worry.
confusion. Yeah.
Fair enough, no problem. Don't worry, doctor, about right or wrong. This is learning platform. Nobody
Yes.
will.
Maybe it's a small or not, but I'm just confused. More probably small, but maybe
But
you will correct me.
but once you listen the answer, you will never forget. Believe me, lifetime you
Okay.
will not forget.
Thank you, sir. Thank you.
Because you interacted, na? So you
Sir,
will.
memory problem, sir. Memory problem. As we are getting old, we are losing our memory. So we got to revise again and again.
I can't ask your age in openly, but probably you
Yes.
are younger than me.
Yes, sir. Okay.
No problem. Great, wonderful. It's a mindset. Nobody is old at the age of 91. Just change the mindset. Anyway, so lung cancer, right? Many questions we covered in next 2 minutes. Lung cancer. Two main entity. One is non-small cell lung cancer, and another is small cell lung cancer. We shortly called as the SCLC and NSCLC. Non-small cell lung cancer is around 80 to 85% cancers are non-small cell lung cancer. Hardly 10 to 15% of the cancers are small cell cancer. In non-small cell, here only one histology, small cell. Why small cell? Because under microscope, they are small, right? So this is how they histologically grade the disease. And non-small cell, three entity. Most commonest, another question, adenocarcinoma. Second, squamous cell carcinoma. Third, here small, so somewhere is large, na? So this here is the large. No need to mug up. Is that clear to everyone? Yes or no?
Yes, sir.
Right? So this is the biggest major classification internationally, right? So lung cancer, non-small cell or small cell, right? The highest is a non-small. Amongst non-small cell, right? So if you see the 100 patient of non-small cell, out of 100, 70% is adenocarcinoma, 25% is small cell, and this is less than 5% large cell. This is how classified. So what the question? What is the commonest cancer in terms of histology, right? So first answer is non-small is more common. So this is one question in exam. Amongst non-small cell, which one is the highest, right? It is second question, right? Adenocarcinoma. Third questions, which is commonest in the smoker? Then it is a squamous cell carcinoma is a third question in the exam. Is that clear? So in one question, there are a lot of questions. Is that clear to everyone? Yes or no? Right? Let me jump little more. Right? This is the lung. This is the lung. Difference between small and adeno, radiologically. Right? So radiologically, remember in that way, small cell and squamous cell both have S, small and squamous. They are centrally located. Centrally means in the center. And adenocarcinoma, peripherally located. Biggest radiological. So if you find somebody with a peripheral tumor, likely it's adenocarcinoma. And why the small cell and squamous cell present early? Because of obstruction. Until and unless you develop the obstruction anywhere in your airway, you won't go to the doctor. They won't develop cough. They won't develop hemoptysis. They won't develop some compressive symptoms. Peripherally, what happens? If situated here, it becomes this. Until and unless bronchus comes in the picture, it keeps growing. So very bad part with the adenocarcinoma is that until and unless it develops in advanced stage, you won't get any symptom. That's the bad part of the story. That's the bad part of the story. Believe me, right? So squamous and small cell, they present early. Why? Because they are centrally located. So SSS, centrally I put it as squamous, small, centrally located. That's it. No need to mug up. So this is centrally located. This two histology, adenocarcinoma peripherally, that is why they are not present. While squamous cell, they usually present in very early stage. So this is very interesting story about this carcinomas, right? So you need to remember this, right? So I am not going much in detail, but this is a clinical presentation, how I see the patient in my OPD in day-to-day practice, right? So I try to correlate whatever I'm teaching you. I'm trying to correlate. I'm not just mugging up in my OPDs and seeing the patient. I try to correlate whether I see 10 patients in a year of non-small cell, how much is adeno? So my statistic is matching with the international statistic. So why should we go with someone else's statistic? No, we can create our own statistic by reviewing our own patients. That's it. So this is what it is written here. So not going much in detail. I simplified these things in a graphical way, right? So again here the non-small cell 85%. I told three squamous, large cell, non-small cell, right? And the treatment little change. Let me go little further here because there are lots of questions here in the lung cancer. So everyone should know the lung cancer. Believe me, everyone should know lung cancer. Cervical cancer, breast cancer, lung cancer. Hot favorite. All three questions comes in exam. Commonest cancer in female. In general, commonest cancer in female, right, is a breast cancer. Question change. Commonest cancer. If somebody asks you, what is the commonest cancer in female in India? Breast cancer. What is commonest cancer in United States in female? Breast cancer. What is commonest cancer in Middle East country? Breast cancer. So breast cancer leads the list of the cancer. It's a first. Now question little change. Most fatal cancer in female. The answer is a lung cancer. Most fatal is a lung, but most common. So it's a different. No? Most common could not be a fatal. Could not be a fatal. And most fatal could not be a common. So if they ask most common, breast, most fatal, lung. That's it. This is two questions. Commonest histology classify, I told you, non-small cell, and among non-small cell, adenocarcinoma is the most common, right? Biggest risk factor for the lung cancer, very important question, smoking, tobacco user, right? 90% of the lung cancer is related with the use of tobacco. Diagnosis is done absolutely by biopsy. Can anyone tell me how you differentiate tuberculosis and lung cancer? Can anyone tell me? Open for all. Can anyone tell me how you differentiate tuberculosis and lung? Tell me. Any one point, if it's in your mind by your clinical knowledge or experience, that you can, okay, sir, yeah, okay, fine. This is tuberculosis. This is malignancy. Anyone? It's a simple question. I did not ask. Yeah, so TB shows caseating granuloma. So how do you know, Dr. Midila, caseating granuloma? Where will you see? Where will you see the caseating granuloma means what? Tell me a little bit about caseating granuloma. What you understand by caseating granuloma, or where? Which is the site where you see the caseating granuloma? Tell me. Macrophage with epithelioid cells, apical lesion. Okay, there are few things. So apical pneumonia can become at apical. Lung cancer is also present with the apical tumor. Pancreas tumor, basically Pancreas tumor is what? This is the lung, right? This is the lung both sides. So if the lung is in apical region, there is one entity in oncology is a Pancreas tumor. Have you heard of Pancreas tumor? So Pancreas tumor is also seen in apical. So how do you know this apical is Pancreas tumor or it's tuberculosis? right? So lymph node biopsy, right? So end of the day, biopsy is the only answer for differentiating the tuberculosis versus lung cancer. At least believe me, in 20 years of my practice, I've seen more than hundreds of patients who treated outside in a periphery, smaller center with the tuberculosis. They are taken ATT, AKT, 3 months, 4 months, but they won't get any improvement in any symptom. They have cough, they have fever, they have evening rise fever, weight loss, hemoptysis, pleural effusion, lymphadenopathy, weight loss, everything there. They are keep taking this AKT, right? And many of them are taking empiric, right? Without tissue diagnosis, no AFB, no nothing. And they're taking on the clinical ground. Oh, it's classical AKT, tuberculosis, start AKT. Don't start AKT. Try to confirm microbiologically. So only way to confirm is the biopsy. So if you do the biopsy, your job is done, absolutely done. Whether you do the biopsy from lymph node, it's fine. You do the primary from lung mass, it's okay. Anywhere, right? And even if you do the biopsy, even say in caseating granuloma, you see in lymph node biopsy, so it confirms that okay, tuberculosis. So biopsy is the best mode of diagnosing the thing. So this is why I put it here. Biopsy treatment options, right? Latest, there are a lot of latest treatment options. Can anyone tell me quickly which is the tumor marker for lung cancer? So if I'm treating one patient of lung cancer, I want to do one tumor marker. Which is the tumor marker blood test? Tell me quickly. Anyone, open for all, fast, quick. Right? So the tumor marker is CEA. Remember, carcinoembryonic antigen. Carcinoembryonic antigen. It can be released from the lung epithelium or lung mucosa. It also causes release from the colon or large intestine. Right? So it is a tumor marker for lung and colon. So when you are treating any patient of lung cancer or colon cancer, try to do baseline CEA tumor marker. Right? In non-smoker, it is less than 5, and in smoker, less than 10. This is a normal range. So if somebody has baseline when lung cancer started with 50, right, it helpful in the follow-up. Very important tumor marker, right? And targeted therapies, right? Sorry, nowadays are there, right? So we know the three treatment for cancer. One is a surgery, another is a radiotherapy or radiation, and another is a chemotherapy. That's it. Our knowledge is limited to this only. But let me tell you, friends, now beyond these things, now what comes in the market is a targeted therapy. So don't lose your hope being a clinician. Another is a immunotherapy. If you heard the name, very important. So targeted therapy, immunotherapy, these two therapies are extremely important and minimal side effect, right? And patient has a good quality of life with this drug without admission, without major side effect, tolerated well, easily available. So whenever your patient comes, try to evaluate for most of the cancer, is targeted therapies available for this cancer? Is immunotherapy, can patient afford, or can patient can take the immunotherapy for this cancer? Answer is yes for the most of the cancer. So try to give the options to your patient. Don't leave them alone that, okay, fine, you have a lung. Let me give you one example. Sanjay Dutt. You must have heard the name of Sanjay Dutt. He is suffering from lung cancer stage 4. Go and read on the internet. Lot of literatures available for Sanjay Dutt. He took the immunotherapy. Name is pembrolizumab, and he is absolutely doing fine now, right, with the stage 4 lung cancer. So can you see how the prognosis change with the one drug, right? If you don't add the immunotherapy or targeted therapy, they usually stage 4 die within 6 to 9 months, and now he is living more than 2, 3, 4 years after the diagnosis and absolutely enjoying normal life. So must give the options of all the current treatment to the patients, which is coming up in the market of oncology. Let's move to the next question. It's a very interesting topic. 55-year-old smoker has a 1.5 centimeter calcified nodule found on the X-ray done for the pre-employment screening purpose. Right, so 55 years man went for some employment somewhere, right? He found that there is a calcified nodule of 1.5 centimeter on chest X-ray. He has no cough, he has no chest pain, he has no dyspnea, he has no weight loss, he has no hemoptysis, he has no comorbidity as well. What would you do for this patient, or what should you do? What you advise? You are going to advise this patient that, okay, don't worry, you go and do the excisional biopsy. You find something on the chest X-ray you want to confirm, so you are going for a CT scan of chest or HRCT. You want to confirm right? With the PET scan, whether it is spread at any part of the body beyond the chest or not, right? You find that this is lung cancer, so you go directly for the bone marrow, bone scan. You go for some genetic testing first to find the what is the risk and how you treat, or else, I mean, he is asymptomatic. Na? He has no cough, no fever, no pain, no dyspnea, nothing. So he's fine. He just went for the routine. So you don't do anything, na? Do nothing for this patient because he's asymptomatic. Just ask him, okay, don't worry, gentlemen, come after 3 months. We'll see if something is wrong. We'll treat you. That's it. So this is what your advice is for this gentleman. So now I want to understand what's your advice for this gentleman. What do you want to do? Who is absolutely asymptomatic? He has nothing at all. He just went for routine screening, pre-employment. He found, oh, something wrong. 1.5 centimeter nodule in lung. That's it. Okay, Dr. Sahar, can you tell me why you want to do the CT scan? Dr. Sahar.
So because X-ray is just a baseline, so I would like to see if, like I'm confused whether I will do the CT or PET scan of the whole body, because I will just not rely on a single lesion. I'll also look for the other lesions in the body.
Fair enough.
I mean,
No, we'll discuss. Very interesting question. So what you want to do now? CT scan you want to do?
usually what we go for is CT whenever we have done the X-ray, we
Fair
jump
enough.
on to
So what I
front.
understood from your talk is you want to go for CT. Is that clear? Am I right or wrong?
Yeah,
Fair enough.
yeah.
I'll give you the scenario. I did a CT scan of this patient, right?
Okay.
You ordered CT scan, right? I'm a good clinician. I followed your instruction. I did a CT
Right.
scan of this patient. CT scan showing the same thing. There is a 1.5 centimeter calcified nodule found on the mid zone of right lung. Right mid zone, you find 1.5 centimeter lesion in the lung. Rest of the CT scan is normal. Now, what you want to do?
Now I'll go for excision, I think.
So why can't you go for excision earlier?
Just to be more specific.
So the guideline says, see, risk factor. Now look at the risk factor. If this patient is non-smoker, na, or this patient is less than 50 years of age, your answer is correct. Got it? You want to confirm, obviously. Chest X-ray is a simple modalities, right? You want to confirm with the CT scan. This is how I mean, also try to look into my OPD, but I need to look for the risk factor. So 3 risk factor: age more than 50 years for smoker, another is a smoker, and anything more than 1 centimeter until proved otherwise it considered as a malignancy. Is that clear to you?
Yes, sir.
Is that clear to you?
Yes, sir.
Excellent. What's the thing? Excisional biopsy should be done on all solitary lung nodule. Solitary means single, right? Multiple, too many. Solitary lung nodule, which has a size of more than 1 centimeter. Very clear cut message. Is that clear, Dr. Sai, to you? So anything more than 1 centimeter solitary lesion in a smoker of age more than 50, I told you, until proved otherwise is a lung cancer or lung cancer, you don't want to miss, go for directly biopsy. Whatever you do, say for example, you do CT scan, you do the PET scan, you do all scan, you do genetic scan, you do genetic study. Eventually, anyhow, you have to do the excisional biopsy. You understand? Just to confirm whether it is cancer or not. Why you are doing the CT scan? Why you are doing the PET scan? Just to make sure that it is cancerous or not. More details, more lymph node, other pathology, histology, blah blah. You want to see, right? Am I right or wrong?
Yes,
But
sir.
even though whatever the radiology is available in this world to confirm that this nodule is cancerous or not, you need to do the excisional biopsy. So you go for, because there are 3 strong reasons: smoker, more than 50, more than 1. If it is a 0.5 centimeter, if it is a 40 years of age, if it is a non-smoker, answer will change. CT scan. Simple. Is that clear? Is
Yes,
that
sir.
clear? Wonderful.
Yeah.
So this is how we have to approach. So this is the guideline. It's not my word. It's a book word. Whatever I'm speaking, it's all from standard book. I did a lot of exercise before preparing this. So you go and read it again once again, but just I'll try to make you understand. right? Another question in exam, lung cancer screening, when to do the lung cancer screening. So very important, right? Age again here 50 to 80, 55 to 80 years, lung cancer screening, 55 you start, stop at 60. To whom you do at least 30 packs per year, right? Those who are doing, they are at high risk of developing lung cancer. So keep these four things in mind. One is age, 55 to 80. Who deserve this screening, right? So somebody is non-smoker, right? Age, younger age, don't need, no need, like you and me, we don't need, we are not smoker, we are not more than 50, we are young, right? Don't need. But somebody is 50 to 55 to 80, somebody is smoking 30 pack. What will you do? Annual CT chest you can do to early pick up something wrong in the chest. You can pick up by doing the CT scan, right? So this is all the three things is very, very important for you to understand and keep in mind for the lung cancer screening. Is that clear to everyone? Right. So this is also again a question in exam, right? So it's very important. So that's it. This is not much. I'll go in detail, but the basic things what you need to know. This is the most, very, very most question comes 100% in exam for everyone. So concentrate. Breast cancer. Which of the following screening test lowers the mortality the most? If you do the mammogram above 50, if you do mammogram above 40, if you do colonoscopy, you reduce the death. If you do pap smear for cervical cancer, stool for occult blood for colon cancer, PSA for prostate cancer. So by doing one test, you feel that you can reduce the mortality, means death, right? So what they're asking, right? Which of the following screening test lower mortality the most? So by doing a one test, right, which gives the highest benefit in reduction of the death, which one is the test? Name the test. So yes, let me check little quick answers from the chat box. Yes, anyone in the house, any volunteer?
Sir, it's mammography above 50.
Okay, so why not above 40?
Because the breast cancer is more common after 50. I read
Okay,
it a day
okay,
ago.
so okay, fair enough. I'm just trying to understand your explanation. Okay, so what's other problem at the younger age? Why government can't start globally that, oh, every woman above age of 40 across the globe should go for mammogram? What's the disadvantage?
Sir, obviously, this will cause
Because it's
financial
an expensive test.
Okay,
financial burden.
let's make a test in, let's make little list. One is expensive
Radiation.
test, one is expensive. This is how we learn, no? We don't need to mug up expensive, so we don't want to do it at early age because there are a lot of cost to the government, right? Okay, what radiation? Somebody spoke radiation. So radiation is the same in 40 or 50. What's the difference? Next, what else? Any point. It's open for all. Tell me, no? Why we are not doing at 40? Why we are started at 50?
Menopause?
So
Uh,
what's the
Sir,
difference?
it depends on the various factors like age factor, like family history, or we have other options also. If there is a clinical some mass, there is a suspicious of some cancer, then we can go for the mammography. Otherwise, we can detect the lesion by ultrasound also. I think like
Fair enough.
maybe you can add.
No, no, I will definitely add. Fair enough. So basically, the two things. One is younger age. I mean, 40 is young, 50 is young, and by the way, female at any age is young. So this is 40, this is 50. So what happens? 40 is quite young. Breast is a dense breast or breast tissue, breast parenchyma is quite dense and tight. There are more chances of false positive result in a younger age. False positive. This is the biggest reason, right? False positive means what? When you do the mammogram, right? You may see something because breast is quite tight and dense, right? Right, so you may see some kind of artifact, something wrong, right? Or you can read, radiologist can read something doubtful, some calcification, right? And there is a wrong biopsy can be attempted on this patient because something suspicious, everybody will go for biopsy. So false positive results are high at younger age, number one, right? This is one medical scientific reason. Number two is expense, obviously expense, because right, if you do at 40 years of age, for every female in your whole country, you need to spend, right? Even after spending the things, if you see how many females less than 40 develop breast cancer, how many 50 or more than 50 develop breast cancer. So here 50 or more than 50, 90% of the female develop, here 10 or less than 10% develop, right? So what, how you select, I mean, where you want to spend the money on 90% or 10%. So maximum where or which age group you can detect the breast cancer is a elderly patients, right? And that is why you need to do it, right? I have seen, I have a patient treating who has a 19 years, 19 years of girl, school going girls, has a bilateral breast cancer. I am treating, I had given chemotherapy. I have many patients below 40 years old of age in my practice, right? But if I see the age wise, hardly 20% are less than 40, 85% more than 50 or 50 plus, right? So this is the general guideline, right? So the answer is a mammogram, because mammogram is reducing the death highest amongst all the tests, right? So here the mammogram, this all question list will come soon, right? So what are the other questions? Mammogram screening in general population, what is BI-RAD classification, commonest site of the breast cancer, commonest histology of breast cancer, what is ERPR HER2, what is BRCA1 BRCA2, right, which is very famous after the Hollywood star Angelina Jolie, right? You go and read it, Angelina Jolie, right? She did it bilateral prophylactic mastectomy because she carries this gene, right? BRCA1 and BRCA2. So we'll discuss what is MRM, modified radical mastectomy versus breast conservative surgery, and right, when observation is correct answer in a breast lesion. So these all are question in exam, right? So in one question I put a lot of questions. So we'll discuss all very quickly in the next question, because when I explain you something, all the questions A to G is answered. So just stay tuned, right? This is the breast, right? Four quadrant, upper, outer, lower, outer, upper, inner, lower, inner. This is the guideline, as I told you, right? This is a guideline from again the book. I took the picture screenshot, right? It is started at the 50 years of age and stop at 75 years. Do it 1 to 2 yearly, at least annually, closest is annually or 1 to 2 year, right? Screening before 50, screening before 50 is no longer routinely recommended. When less than 50 should only consider mammography screening based on high risk individual for early onset of breast cancer. So if somebody comes to me and tell me, my sister has a breast cancer, my mother has a breast cancer, my cousin sister has a breast cancer, and she is now 42 years of age, I'll tell, okay, madam, you go and get the mammogram. Why? Because it's a high risk group. 3 people, 3 generation, 3 first degree relative have a breast cancer in family, ovarian cancer in family, right? So they must have to do early mammogram. But in a routine, if in your family nobody has a breast cancer, mother is fine, grandmother is fine, all sister fine, all cousin fine, everybody. And if you come and tell me, sir, I am 35 and should I go for mammogram? I'll say no. No risk factor. Everything is fine. No history, family history, no risk factor. Go after 50 years of it. That's it. So history is again important. Right? That's it. Let me first breast finish it. So I won't miss out anything. And this is the questions where we cover all that questions, right? 68-year woman visits her physician with a solid peanut-shaped hard mass in upper outer quadrant of left breast. A biopsy of the lesion reveals infiltrating ductal carcinoma. What is the next step in the management? So they are asking for the management, means treatment. Lumpectomy with lymph node sampling plus radiotherapy, modified radical mastectomy, modified radical mastectomy plus radiotherapy, neoadjuvant chemotherapy plus lumpectomy plus radiotherapy and tamoxifen and radiotherapy. I don't just need the answer. I need an explanation. I would be happy when somebody gives me the explanation. ABCD we can click, anybody can click, but you need to have some logic why you selected. It's okay, fine. If you are wrong, I am happy, no problem. But at least try to understand the scenario, try to understand the logic of answer, what you had given. Yes, let me. Yes, Varun. Varun,
Yes, sir.
you I think opted for D, if I'm not wrong.
Yes, sir.
So let's discuss little bit, right? So that gives us idea, right? So D you selected. So now start. Why you selected D? First of all, tell me what is neoadjuvant chemotherapy. First
Uh,
step is neoadjuvant. So explain me what is adjuvant, what is neoadjuvant. You
Sir,
don't know? Say no, don't worry. Just we are discussing.
Sir, I'm not sure, but these are those drugs which targets those specific receptors which can yeah, estrogen and progesterone receptors which influence growth of the cancer, sir, if I'm not mistaken.
No, but what is the receptor status here? Receptor status is not given here. Not given means normal. Here there are three receptors in breast cancer: ER, PR, and HER2. These are the three receptors globally people are targeting to treat the breast cancer, right? So ER is estrogen receptor, PR is progesterone receptor, HER2 is human epithelial receptor type 2, type 1, 3. There are a lot of, but here HER2, right? So these three receptors are targeting in breast cancer. We are treating every day the same thing, but here nothing mentioned about the targeted. Second thing, neoadjuvant is what? For everybody, neoadjuvant means what? When you give chemotherapy prior to surgery or before surgery it is called as a neoadjuvant chemotherapy. So somebody worked in oncology, they have seen this word every day, NACT, neoadjuvant chemotherapy. And after surgery, if you give chemotherapy, it is called as a adjuvant chemotherapy. Adjuvant. This is neo means before, adjuvant means after. That's it. So this is neoadjuvant. Before surgery, you want to give some chemotherapy plus lumpectomy plus radiotherapy. So how you justify, na? First of all, why you want to give chemotherapy? First, why you don't want to go for surgery? You get my point,
Oh, yes, sir.
right? I will clarify everything. Don't worry. Any breast cancer question you will be master in next 5 minutes. Everybody, because the what I'm going to give you, this is absolutely not in any book in the world. Believe me, this is from my experience and my treatment. I'm telling you, 5 treatment options available in this world right now. First is surgery. Second is a chemotherapy. Third is a radiotherapy. You must take a picture. You 100% not get in any book. Fifth is a targeted therapy. And fifth is a hormonal therapy. So any medical oncologist is now treating, this is a standard guideline. There are lots of therapies, gene therapy and all. It's all investigational. I'm talking about evidence-based medicine as per the book guideline. So this 5 is available, right? If you remember this chart, any breast cancer questions can be solved very, very easily. Surgery. There are 2 type of surgery: MRM, modified radical mastectomy, BCS, breast conservative. What is MRM? Right? If right MRM is done, means right side of whole breast is removed. So right side of breast is nothing. It's just chest wall. Only left breast is preserved. Right? So this whole breast is removed. This is just the chest wall. Here breast conservative surgery, both breasts are as it is. What they do is just lumpectomy and they did the axillary clearance. This is called breast conservative. The name itself suggests breast conservative. Breast is conserved, right? Whole breast is not removed, and this is the standard of care nowadays. We don't need to remove the natural organ of the female, right? To remove the whole breast, because once they cured of breast cancer, they have something lacking in their body is a breast. Why? Because you remove the whole breast of the lady, right? So after cure, after 2 years, 5 years, if you ask them, they're not happy. Why? You remove whole breast. So give options of breast conservative surgery as far as possible. So this is one thing, right? Chemotherapy, right? So what is the indication of surgery? Again, indication, we need to know indication for all, indication for all. Where when we give, this is one biggest question in everybody's mind. Sir, when we do surgery, when we do chemo, when we do radio, when we do target, when we do hormonal therapy. So I'm coming on that point. So everything is crystal clear. So surgery is done. Usually, have you heard of TNM classification? TNM, tumor node metastasis. So if the tumor is less than 5 centimeter, right, node is negative, and there is no metastasis, you can go directly for the surgery. Simple. That's it. This is all done. Simple. And this TNM can be done, right? Tumor node metastasis by radiology. Before going surgery, radiology, either do CT chest abdomen, right? And if your CT is high-fi, resources available, do CT scan, PET CT scan. That's it. If PET scan not available, don't get confused. Do CT scan. You want to just make sure that from the breast, it does not goes to the lung, it does not go to the liver and bone. That's it. So if you find that it is a localized disease, tumor size is less than 5 centimeter, no nodal involvement, no distant metastasis, go for surgery and give both the options to the patient. Let the patient to decide what to go for or not. Chemotherapy. Again, tumor is more than 5 centimeter in size at the time of presentation. Node is positive at the time of presentation. Metastasis is present at the time of presentation. You go for chemotherapy first. And first, before surgery, if you are going for chemotherapy, it is called as a neoadjuvant chemotherapy. If it is done after surgery chemotherapy, so first you do the breast conservative and give chemotherapy, it is called adjuvant, right? But first you give chemotherapy and then do breast conservative surgery, it is called neoadjuvant. That's it, it's clear cut. Radiotherapy, again, the tumor size, right, is more than 5 centimeter, they deserve node positive, they deserve radiotherapy, right? So these are the two conditions where the radiotherapy deserve. And locally advanced breast cancer, they reserve. And breast conservative surgery, if they're done, they deserve 100%. So three criteria mainly: tumor size large, node axillary positive, and breast conservative surgery. It is 100% mandatory to prevent the local recurrence of breast cancer. You did just lumpectomy, axillary dissection in breast conservative, give the radiation to the chest wall. It's mandatory across the globe guideline, right? This is the third treatment. Indication targeted, right? So target is what? HER2. HER2 is one gene. So this is a breast cancer cell. Breast cancer cell, there are three receptors which is situated. If it is positive, you treat them. If it is negative, don't treat them. Estrogen receptor, progesterone receptor, HER2 receptor. This is breast cancer cell, right? So look for these three receptors, whether they are present or absent. So if the HER2 is present or positive, there is one drug available in the market called as a trastuzumab. Trastuzumab. So if the HER2 is positive, you give the trastuzumab. And if ER, estrogen receptor, or PR, not both the things are needed. Either of this, either estrogen receptor positive or progesterone receptor positive or both positive, they deserve hormone treatment for 5 years. The name of the drug is tamoxifen citrate for premenopausal and anastrozole for postmenopausal. Anastrozole. That's it. This is the conclusion. Take a picture. You won't get this chart in any book. Believe me. This is when you read whole the chapter for any book, you get confused end of the day. This is the most simpler version what I can present to you by my experience in a simpler way. If something comes, you need to answer in that way. Is that clear to everyone? Yes or no? At least reply me. Is that clear to everyone, this chart?
Yes, sir.
Probably, I think this is the most finest version I can produce to you, believe me. Varun, are you there?
Yes, sir.
Now You got this concept?
Yes, sir.
You got this slide concept, 5 treatment.
Yes, sir.
Now simply remember, now you try to answer the question. We'll discuss again. We are not in hurry. We'll discuss 2 question less, but whatever we learn, we'll learn 100%. Right? So 68, right? Female 68. We'll go again, 68 female, right? Okay. Right. What else? Right? 68 years female. Then 68 years female present to her physician with solid peanut. Peanut shape means small shape, right? Peanut is how much? Around 2 centimeter, roughly. Right? Hard mass in upper outer quadrant of left breast. The biopsy showing infiltrating ductal carcinoma. What is the next plan? So when patient comes to you with a small tumor size of less than 2 centimeter or 2 centimeter or 3 centimeter, what will you do first? If this charts you keep in mind, what will you do first?
Sir, a
What?
surgical intervention.
Surgical, right? So forget about this, right? Forget about those things right now, which is not surgery is not mentioned. So see, tamoxifen and radiotherapy, there is no surgery, so remove that. Simple, right? Here neoadjuvant not required because it is less than 5 centimeter, right? So why you want to give the neoadjuvant? It's already small, so remove this, right? Here surgery, here surgery, here surgery, right? So you are little confused amongst these 3. What will you select? DN is absolutely gone. So what you want to do for this patient now? Tell me. In surgery again, think na 2 things, gentlemen. MRM you want to do, or you want to do breast conservative surgery. These are the 2 options. So look into the options once again. I'm not in a hurry.
Breast conservation.
Breast conservation. So breast conservation is what? Modified is not breast conservation. This modify is not breast conservation. So this is the answer. Even if you don't understand anything, you do the lumpectomy. Again, I told you, go to my picture, right? I explained in that way. Breast conservation is lumpectomy plus axillary dissection. Am I right or wrong? This is what I taught you, isn't it? Yes or no?
Yes.
Right? So this is, right, breast conservative surgery where whole breast is not removed, just lumpectomy and axillary dissection. So here the same thing, lumpectomy plus axillary dissection, right? So lumpectomy and axillary dissection or lymph node sampling, that is axillary dissection. And when you give this, radiotherapy is must, mandatory. Again, see my slide. Again, see my slide. Radiotherapy is must. When? 4th, I mention here clear cut, right? Breast conservative surgery, 100% radiotherapy is a mandatory. Am I right or wrong, Varun?
Yes, sir.
Is that clear? So
Yes,
the
ma'am.
answer is lumpectomy, means breast conservative surgery. And when there is a breast conservative surgery, it is absolutely radiotherapy is must. Now this open for all. Any question? Open for all. Any question? Any confusion? So now just remember, na, when they ask you for the hormonal treatment, you go and look. If ERPR is positive, you go give a hormone. If negative, no need to give hormone. Targeted therapy, HER2 positive, you give trastuzumab. If negative, not required. That's it. No need to mug up. BRCA. BRCA is what? When are the BRCA1 and BRCA2 genes tested or indicated? Again, I given the example of Angelina Jolie, the Hollywood star, and Brad Pitt, right? Angelina Jolie. You go and little bit read interesting story. Don't just read the book, right? So BRCA1 and BRCA2, these are the gene which is responsible for getting cancer hereditary, right? So when this test, if somebody patient comes and asks me in my OPD, sir, I want to do BRCA1, BRCA2, am I eligible? Right? Do I qualify for this test? Are you advising me this test? What's your opinion for doing this test? He has no financial problem. He can spend any number of money. My patient is a millionaire, but it is not for all the patients. This is guideline. Family history of early onset. So somebody is less than 50 years of breast cancer, or even if there is a no breast cancer in family but young, you can go for BRCA1, BRCA2. Second, ovarian cancer at any age, right? So ovarian cancer at any age, right? They must do. So some female, right, less than 50 years of age, do BRCA1 and 2. If family history of the same patient has mother has a breast cancer, do BRCA1 and 2, right? Patient has ovarian cancer 10 years back, they deserve doing BRCA. So it's just not for the breast, it is also for ovary, it is also for pancreas. Now go and read it. Any patient with diagnosis of breast or ovarian cancer, family history of male breast cancer. So male breast cancer, if they have the breast cancer, go, because it is not common in male. So there is some kind of genetic inheritance, and that is BRCA1 too. So do in a male breast cancer, and this is the Juvis heritage. Rare, I have not seen much in my practice in 20 years, but it's written in the book, so I mention it here. So these are the only few indications where you do a BRCA1 and BRCA2. So don't forget it. There are a few other things added in this list, right? Let me tell you that as well, which is not, and we do practically, we do a lot of BRCA tests in our OPD every day, right? BRCA1, BRCA2. So in this list, little more things. One is a triple negative breast cancer. Triple negative is what? ER negative, PR negative, HER2 negative. We do BRCA1 too. Number two, young female premenopausal, we do BRCA1 and 2. And family history of breast cancer, mother, sister, cousin, sister, we do BRCA1 and 2. Right? So this is how we approach clinically, and it is in the latest and recent guideline. So just keep in mind, but at least these things you have to keep in mind, how to treat a breast cancer, irrespective of the exam, irrespective whether you are, I mean, whether it is asked or not, you must 100% know the treatment modalities of the things. Last couple of questions. A 25-year-old woman with a 15 weeks pregnancy, we'll discuss your queries later on after this session, maybe in 15 minutes. A 25-year-old woman with 15 weeks pregnancy by dates is found to have HGSIL. What is that? High grade squamous intraepithelial lesion on a recent pap smear. So this is what I earlier told you in the first earlier 3-4 pap smear, right? So one, you need to know pap smear. Again, revise. Start at 21 years of age, stop at 65 years of age, do it every 3 yearly if you are doing a pap test. That is what I already explained you. If you are doing with HPV, right? So you are doing pap plus HPV, then you do at 5 years, age is the same. So if you do a pap test for someone, in pap test you find there is a HGSIL, means high grade squamous intraepithelial lesion you found on a pap smear. What you do, right? So this is what the question is. So HGSIL on a recent pap smear, you did a pelvic examination. There is a gravid, means pregnant uterus, consistent with 15 weeks of size, and cervix is grossly normal to visual inspection. So you do the examination, right? Lower perineum, you try to see cervix is fine, vagina is fine, everything is okay. Gravid uterus is enlarged, there is fine, grossly normal. You can see the cervix with speculum looks okay grossly. What is the next step in your management? So you have one patient who is 25 years on routine or recent pap smear. She is a pregnant lady, and on this you find this. What will you do? You do colposcopy and biopsy, you do cone biopsy, you do endocervical curettage, you do hysterectomy, you repeat after the pregnancy because patient is fine, just nothing to worry. So what will you do? To tell the patient, let this pregnancy to finish, and then we'll see what happens. We'll look into it. Yes, Dr. Faisal, any comment? Dr. Faisal. There are 30 people in the group, but just answer is 3, 4. Why so less answer? If you cannot speak, it's fine, but at least post some answer. No? If the same question comes in exam, you need to post something. No? Right or wrong, forget about right or wrong, but post something. Okay, so most of the people are saying it's a colposcopy and biopsy, right? So can you, Dr. Sonali, tell me what is colposcopy? If you would like to interact with me, Dr. Sonali, can you little bit speak up? Anyone now, open for all. Anyone?
So rifle examination through just like colonoscopy or other scopes.
Okay, so why you don't want to do the cone biopsy? Why you want to do the colposcopy and biopsy? Cone is also biopsy, colposcopy and biopsy.
Sir, in cord biopsy, there is a high risk of abortion because it takes a portion of the cervix. So the abortion chances increases. And colposcopy, we use a machine under GA to examine the cervix and take a biopsy. So just to see, this is my view.
Fair enough, fair enough. That is the thing. So, colposcopy, colpo means vagina and scopy means seeing directly, endoscopy, bronchoscopy, right? So, nasal endoscopy. So, this is scopy is visualizes and colpo is vagina. So, you see the vaginal part, you see the lower uterus and cervical part, right? Try to identify the lesion, right? Right? And you do the biopsy. You do the biopsy because on pap smear, you did a pap smear already. There is something suspicious, which is high grade squamous, blah blah. It could be malignant, it could be benign. But how do you differentiate? It's by doing the biopsy and biopsy of the cervix and with the colposcopy, right? So colposcopy and biopsy is the correct answer, right? Hysterectomy is obviously too aggressive, right? She is a pregnant. No need to repeat after pregnancy. You need to do it right now because she is quite young, 15 weeks. So still long way to go. So before that, she may develop full-blown cancer. So don't wait for the pregnancy to finish. Endocervical biopsy or curettage is absolutely contraindicated because of pregnancy. And colposcopy versus cone biopsy. So cone biopsy, better you go visualize, try to find out the things and then do the biopsy. So colposcopy plus biopsy would be the preferably the most suitable answer, right? So this is what I already explained you, so not going much in detail, right? This is one another interesting questions frequently asked in exam. 35-year-old woman is referred because of pap smear reading of oscus. Now what is oscus again, right? Oscus, because there are a lot of terms coming, right? So this oscus is what? This is oscus. So oscus is atypical, ASCUS, atypical squamous cell of undetermined significance. Atypical, not typical, atypical squamous cell of undetermined significance. Have you heard of this word? Anybody heard? MGUS. Anybody heard this word MGUS? Yes or no? I'm surprised if you say no. Have you heard the word multiple myeloma? So MGUS is monoclonal gammopathy of uncertain, undetermined significance. So same US, undetermined, unsignificant, right? So you have a one lady who is 35-year young lady. Pap smear, you did it. Pap smear is showing oscus. Her last pap done 1 year ago was negative. So she did last year. She was fine, right? She has been sexually active for last 4 years using combination of oral contraceptive pills. Today, 1 year later, her pap smear reveals oscus. What is the next step in the evaluation? Are you going to do endocervical curettage? Are you going to do colposcopy and biopsy? Are you going to do HPV DNA? Are you going to repeat us after 6 months the pap smear, or are you do it annually the pap smear? Very interesting.
So HPV testing should be done. And then
Why,
we will
dear
decide.
doctor, you want to do the HPV, not directly the biopsy? Just my
Sir,
question.
because this will be more likely to be associated with the cancer, HPV. That will be like, if that
Okay,
is also positive, then we will go for the colposcopy and obviously the
excellent, excellent, excellent. Your concepts are clear. So basically, you did a pap smear. Lots of question in one question, huh? So pap smear can be normal. Do it every 3 yearly with HPV 5 yearly. We discussed already. If the pap smear is Oscars, there are three possibility in Oscars. Oscars could be turned to be normal. It could be some infections, pelvic inflammatory disease, where you also see Oscars, and third is a malignancy and cancer. We don't want to miss this. That is why we are chasing this Oscars. Is that clear to you or not? Yes or no? Right? So once you have Oscars, right? First of all, you need to why you are worried about, what we are worried about is malignancy, and what causes cervical malignancy is by the virus called HPV. So do the HPV first. Do the HPV first. This question may comes in a different way, but if you understand this diagram, what I'm showing you, you can answer question from anywhere, from top, from middle, from bottom. So do, if the Oscars, don't get panic. There are three possibility, right? It could be a normal, it could be infection, it could be malignancy. So what will you do? HPV. If you do HPV, doctor, there are two tests possibility, either HPV is positive, HPV is negative. If HP is negative, in Oscars, you can repeat it. You can repeat it after 6 to 12 months. Because HPV is the 95% of the time, HPV is positive in cancer. If it is negative, less likely. So don't go for the biopsy. You repeat it after 6 to 12 months. Again, after it is Oscars, again, what happens? Again, after 12 months, you did HPV, you did it. It's negative. Again, after 12 months, same patient comes, again Oscars. Then you go for biopsy. Don't worry. This is the answer. Here HPV is positive in this patient. You go for colposcopy and biopsy. Here what they ask, pap smear. Today, 1 year later, pap smear is showing Oscars, the following next step in the evaluation. Right? So based is HPV based on age, HPV infection status. So you need to know the HPV status in each and every patients of the Oscars. So approximately 10 to 15% of the patient with Oscars have pre-malignant or malignant disease, and that you don't want to miss it. And that is why you are doing the HPV. Two pap smear revealing Oscars must be followed with the colposcopy and biopsy that I already told you in the chart. Right? And cervical cancer screening already we discussed, so not going much in details. 16 to 21 to 65. Is that clear to everyone? Yes or no? If anybody doesn't understand, tell me immediately. Is that clear to everyone, respected doctors?
Yes, sir.
Clear? Wonderful. This question will come, so don't make it wrong now. Otherwise, I will not be happy. All my hard work will go away. So this is breast cancer again. Last one or two questions. A 30-year-old woman complain of bilateral breast enlargement and tenderness, which fluctuates with her menstrual cycle. On physical examination, the breast feels lumpy. There is a painful, discrete 1.5 centimeter nodule. A fine needle aspiration draws clear fluid, and the cyst collapses with the aspiration. Which of the following is the best next step in the management of this patient? Clinical breast examination in 6 weeks. Core needle biopsy you want to do. You will go for mammogram. Repeat FNS in 6 weeks. Ultrasound in 6 weeks. Post your answer in chat box. Any volunteers? What's the answer? Any volunteer? Answer, please. Any volunteer? Answer. Somebody is putting E, means ultrasound in weeks. Few answers is clinical breast examination in 6 weeks. CE is also answer, mammogram. Dr. Valyappan, any comment on mammogram? Yes, sir. So answer is a clinical breast examination in 6 weeks is appropriate follow-up for a cystic mass that disappear after FNA. So everything is very clear cut, crystal clear. They have mentioned in the scenario, right? Nothing they have hidden in this scenario, right? They have mentioned very much clear cut, right? So breast cancer is usually not bilateral. So forget about malignancy now. It is not very common at 30 years of age, right? Usually tenderness is not present in breast cancer, and here is a tenderness. Cancer lump does not fluctuate with menstrual cycle. It remains as it is, whether it is menstrual, non-menstrual, premenopausal or postmenopausal. So absolutely all 4 points are against cancer. Now see, on physical examination, breast feel lumpy. There is a painful discrete nodule, right? What is the beauty? A fine needle aspiration shows clear fluid. So in breast cancer, usually hemorrhagic fluid, not clear fluid. Cyst collapses with aspiration. So cyst collapse with the aspiration is again a signs of benign things. So we are dealing with something benign breast lesion, right, which completely collapses after aspiration. So what will you do? Just to make sure, call them, do the clinical examination after 6 to 8 weeks. Right now, no need biopsy at this point. Mammogram is absolutely very early at this age, and there is no evidence of malignancy. So don't do at 30 years of age. Usually screening is 50 years, high risk 40 years, but 30 years not indicated, except you are thinking that it is malignancy. Otherwise, no need repeat FNA, no need repeat FNA. Right, before doing FNA, right, you just do and clinically do the examination. If something is there, again cyst develop, then you can think of repeat FNA. Otherwise, not. An ultrasound will not going to help. Just do the clinical things. If everything is fine, breast is normal, just keep them under surveillance. That's it. This is what the answer is. Any question? Is that clear? Yes or no? Audience. Last couple of questions. This is a most effective method of achieving smoking cessation by use of what? Nicotine patch, bupropion, buspirone, nicotine gum. Probably easy question, but still it's tricky as well. What do you think? What do you think? The most effective method of achieving smoking cessation by use of nicotine patch, bupropion, buspirone, or nicotine gum? Fine. So most of the answers from the pool is B. So that's correct. Bupropion. Let me little read the literature. Right. The most effective method of achieving smoking cessation is the use of oral medications such as bupropion and vernicillin. Right. Bupropion does not contain nicotine and does not help you quit smoking in the same way the nicotine replacement therapy does. But like the other medication, it decreases the craving and withdrawal symptoms. And you take bupropion for 7 to 12 weeks. After you stop using the tobacco, you can take it for as long as 6 months to 1 year, the bupropion tablet. That's it. So this is what the simple questions. And last but not the least, regarding CIN, what we discussed. A 40 years woman present with abnormal cervical cytology on pap smear suggestive of CIN3, that is cervical intraepithelial neoplasm. The next best step in the management means treatment. They are asking what do you manage, how you manage. Hysterectomy you will going to do for this lady, right? colposcopy and LEEP, colposcopy and cryotherapy, and conization, right? So what do you think? What will you do for this lady? Probably gynec expert can answer very easily. And there are a lot of gynecs in the group, I can see. Okay, so let's understand what is CIN. And before understanding CIN, we need to know normal. Without normal, we cannot understand normal. Abnormal. So this is normal. This is a normal pathology or histology of the cells, right? If there is a mild dysplasia, mild, that is grade 1, mild. So you can see all the cells up to here. I'll just mark with a different marker. So yellow one is abnormal. Here the yellow one is abnormal. Here little moderate, small. This is less than 1/3 of the thickness. This is 2/3 of thickness, is a moderate, little more abnormal cell, but not spread beyond the epithelium. Still the epithelium is here. Epithelium is intact, right? And more than 2/3 is grade 3 or CIN3, right? And complete thickness is a carcinoma in situ, complete. So less than 1/3, 1/3 to 2/3, more than 2/3, 100%, but still the epithelium is not breached. And when there is epithelium breach, the cells comes out of the epithelium. It is called as invasive carcinoma. So they are asking what is the treatment of this cervical intraepithelial neoplasia 3, and treatment is a colposcopy, means you see, right, the lower part of perineum and genital regions, right? And you do the colposcopy and LEEP. And what is LEEP? It is a loop electrical excision procedure, LEEP, L for loop electrical excision procedure. That's it. So that is LEEP. So you see, visualize where is the problem. Cervix is the problem. It's a CIN3. So you do the visual impression, try to understand the anatomy. So you do the colposcopy, and through the colposcopy, right, you do the loop electrical surgical excisional procedure. Remove the abnormal tissue by cutting it away using a thin wire loop that carries an electrical current. It must be, or it may be performed after abnormal cells are found during the pap test or colposcopy or biopsy. So you found CIN3 is not a normal. CIN3, if you don't treat it, it will go in next 6 to 12 months to a full-blown cancer, which we don't want to have it, right? So it is good, right? It is a precancerous. So mild is CIN1, moderate is CIN2, severe is CIN3, and carcinoma in situ is, you can say, CIN4 by my sense, or carcinoma in situ, and then full-blown cervical cancer. So here the treatment is a CIN. So that's it. Thank you very much for your kind attention and your this patience listening me, right? Coolly, calmly. So once again, thank you very much. This session is little open for the questions, right? So anyone has any questions, just do let me know quickly so we can in 5-10 minutes pack up quickly, and that's it.
Sir, the CIN 1 and 2, what will be the management?
Let me ask you. anyone in the house, CIN 1 and 2, what's the answer? Gynec experts.
Sir, I think for CN1, we repeat the pap smears.
And
I
two?
guess so. Yeah. Yeah, for the same thing. Means we do the colonoscopy and like that. This is my guess. Basically, I had to read it.
Okay, so this is homework. Keep it at a homework. Chalo. Next. Next. Everyone should go and read breast cancer, cervical cancer, colon cancer, prostate cancer, and 5 things you must read: lung, breast, colon, cervix, and prostate. 100% you will get lots of questions from this only. At least 5-10 questions you will get it in a different way. So I try my level best to make it this. Anything else? Any quick feedback from the audience? Very quick, very quick. Open for all. Very quick. Something you learn first time in your life, new things which you never heard of. Today you learn first time. Everything is in book, but something you feel it very unique.
That table you did for the breast cancer, what do you call the treatment options? That was very useful. I mean,
Great. Thank
yeah,
you. Thank you for
yeah.
your feedback,
So,
sir.
yeah.
Thank you very much. Anybody last 1 minute, any quick feedback? You can post it in our group anyway. So other people who did not
Yes,
join,
yes.
they
It is
also.
an excellent lecture, and we learn a lot regarding the cancer.
Sorry,
And we
sir.
definitely learn. This is excellent lecture, and we learn a lot regarding the cancers. And
Thank
also, we go through for all these 5 lectures, 5 cancers, as you told. So it is also helpful to us in the exam.
Thank you very much, sir,
Thank
for
you.
your feedback. Thank you, sir. Thank you for your time. Yes. Okay, fine. So thank you very much. Let's pack up and we'll announce the next master class. Last but not the least, tomorrow evening, probably the same time, 8:45, I will be in city of Dubai. So if anybody is locally there in Dubai, Sharjah, Abu Dhabi, or Alain, the major 4 parts, feel free to contact me. I will be there for a few days. So we'll keep in touch. Anything, any questions, anything we can discuss personally as well, because I'm full time there only. So just stay tuned, keep in touch. I'll announce for the next lecture, and thank you very much. I just
Sir, thank
humbly
you so much. Thank you so much. We are always, sir, very honored to listen from you. You are a very, very good teacher, mashallah.
thank you very much for your kind feedback. Motivational. Thank you very much. Thank you. Right. So just keep in touch, and I would appreciate if you post some few feedbacks in our group of this January 27 class. So other who did not join also get little motivations. Thank you very much. Good night.